ladies and gentlemen, Chris Sepper.
Hello, and thank you very much. We talk about a patient journey. I want to thank you all for making this journey with us over the last day and a half. And we've saved one of our best for last. And it's interesting, we've talked about patient engagement and the different people who've been fighting the good fight. Our next speaker really has been fighting the good fight longer than anyone. And I think if people will look back at the history of engagement and how treatments changed, his philosophies and the philosophies of the peers that he's worked with are among those. He published a first paper on minimally disruptive medicine in 2009, and I think if we know anything about academic journals, that means he wrote it in 1989. Dr. Victor Montori is the director of the Healthcare Delivery Research Program at Mayo Clinic, and he has been a champion of this phrase, minimally disruptive medicine. He is going to articulate that vision and others for us, but it really takes that idea of less with more and instead says, when you have a patient that is so challenged with so many things, the idea is not to pound more rules and regulations and treatments on him or her, but instead to make it simple and start to create victories, and that will lead to a true medical success. And I am very, very proud for our closing keynote speaker is Dr. Victor Montori.
Thank you very much. That's my Twitter on the bottom. I'm 7 away from 4,000, so maybe somebody here can help me out with that. I'm going to be discussing about patient-centered care. This is a very important slide for me. The work that we've been doing for the last almost 20 years in relation to advancing the interests of patients have been done in the vacuum of funding from groups that could potentially benefit financially from the work that we do. And that way we've kept our independence. One of the interesting challenges in healthcare today is that there's a lot of research, but most of it doesn't matter. You can see the triangle on the graph. The tip of the triangle is probably the stuff about research that matters. Everything else is noise. And then if you look at that point, it has a difficult time making it to the patient for all sorts of reasons, including, at the end of the day, the patient. For many patients with chronic conditions, if the patient fails to understand and agree of what's involved and to adhere to that over time, it doesn't matter that the investigators came up with a cure of anything. If it doesn't get all the way to the end and the patient doesn't follow through with that intervention, the benefits do not materialize. The value of the enterprise is lost. And so when you think about one of the fundamental problems in healthcare today is the fact that patients don't follow clinicians' advice, and 2 out of 5 of those patients, don't, according to some statistics, don't do it. The costs associated with this are staggering, and that's one set of numbers. Once it gets to billions, I don't fully understand, and it's impossible to verify they're true. But it suggests that there is an enormous amount of lost value in healthcare because of non-adherence. It also is associated with poor health cost and side effects. Patients may take the treatments partially, so they will experience the cost, they will experience the side effects of those treatments, but they may not accrue the benefits of them because they don't take them for enough period of time. And then the last bit that is important to me as a diabetes doctor is that it complicates the patient-clinician relationship. I have patients that come to my office, and we discussed last time that they're going to do some diet and exercise and lose some weight and take the medicine maybe differently, and I look at them and it doesn't look like they've done all that, and they look at me and they kind of see that I know that they didn't do what they said they're going to do, and I know that they know that I know that they didn't do what they said they're going to do, and slowly but surely the degree of trust that is necessary between the patient and me as their clinician, that partnership in chronic disease begins to be eroded by the problems of non-adherence. Some people think that this is a problem of patients not having skin in the game, patient responsibility, and they're ignorant, and here's an example of that work from New York, Spanish Harlem. Hispanic patients with diabetes are asked, do you think diabetes is a real disease that can affect your health and kill you? Do you think that treatments are in general safe and beneficial? And you can see there's some accepting folks on your right who think that diabetes is a real problem and the medicines are really safe. But notice that they're very much adherent to therapy. 17% are non-adherent. On this side on the left, you see the people that think that diabetes is not not a real threat, and the medicines are potentially very harmful. And you can see there they have a much greater degree of non-adherence. And so there is something to be said about patients not knowing and having the wrong set of beliefs. But unfortunately, you know, some of the approaches that we have to solve that problem that do not involve maybe helping the patients understand or educate them, but yelling at them. And yelling at people in general does not work. And of course, maybe in other parts of life, just making that statement is sufficient. In healthcare, you need a researcher that does work for 25 years to tell you. And this is what Brian Haynes said in 2002, after 20 years of research on non-adherence, pointing out that coercion is not really a helpful thing for patients. Some of them will, in fact, withdraw from care and stop benefiting from healthcare altogether. So we need to do something better than that. So what happens with poor fidelity to treatment is when the patient basically decides not to follow the treatment, again, perhaps because of incomplete information. And so here, in general, the approach is to improve our communication, our ability to reach the patient, our ability to help them make better decisions. And one of the approaches that we've been using is shared decision-making. So shared decision-making starts with evidence-based practice. Evidence-based practice means you take into account the best available research evidence, figure out what works, what doesn't, and then you take into account the patient's values and preferences and context, and then you put it all together and you come up with a decision that is sensible and reflects both what we know and about the science and what we know about the patient. Our approach basically recognized that in the clinical encounter, we sometimes make decisions with patients, and patients go home and they really make the decision after they leave. They either because they acquire new information, like the neighbor telling them about this drug and the side effects that it has, or the pharmacist telling about the price of the drug, or they get the drug, they go home and they read the package insert, and they realize that the medicine to avoid heart attacks can cause heart attacks, and then they stop taking the medicine. And so we thought, can we not have that decision point happen when the patient can take advantage of the expertise and of the clinician and the evidence from clinical care research? And this is one of the first results of this effort. I think most of you know about cholesterol medicines, about statins. And if you only consume what's on advertisement, you think that statins should be in the water. And in fact, many colleagues think that statins should be given to about anyone that moves. And one of the challenges is that statins are probably one of the best drugs that we have to reduce the risk of heart attacks. But their value depends on your risk for heart attacks. If you are not at risk for heart attacks, it's lower value. If you're high risk for heart attacks, higher value. So here's the situation of a patient is at 20% risk of a heart attack. And we start with, we tell the patient, look, you're in a room with 100 people just like you. And over the next 10 years, you will see 80 in green that will not have a heart attack and 20 that will. I do not know if you're one of the green ones or one of the red ones. If I were to give then a cholesterol medicine to all 100, what will happen? After 10 years, you'll see the 80 people in the bottom here, green, that will not have a heart attack. They will take the medicine, no benefit, right? Because they were not destined to have a heart attack. You see 15 here in red that took the medicine regularly, and despite taking the medicine regularly, still got the heart attack. And then there are 5 in yellow that because they took the medicine, avoided the heart attack. Again, I do not know if you'd be one of the green ones, one of the red ones, or one of the yellow ones. What would you like to do? Now, what is interesting about this is that this is a typical patient, a typical moderate to high risk patient with diabetes. According to the existing guidelines, as of today, all of these patients should be on a cholesterol lowering medicine. So if you think about this and you look at it and you look at that, do you think that's big benefit, little benefit, or no benefit? I suspect most of you who are you're still here, are thinking this is probably little benefit. And yet our guidelines said everyone should be on it. And our IT systems will remind us to put them on it. And we'll have pay-for-performance metrics that will push us to do this. But again, once you engage the patient, like I sort of did with you with this, you start wondering, is this what I really want to do with my life in terms of health? We've done this for osteoporosis. We're cute. We did broken bones on this one. And then we did it also for more complex decisions like diabetes medicines, right? So we have patients with diabetes, and the endocrinologists, they publish these algorithms that tell you it's a very technical decision which diabetes medicine you need to use for each patient. But we looked at the evidence, and what we found was they're all kind of the same, and what really matters here is the side effects, the adverse consequences of these medicines and their costs. Who suffers those? The patient. Well, maybe the patient can choose which kind of harm they want to be exposed to when they're choosing between these pills. And so we ask patients, which aspect of your next diabetes medicine would you like to discuss next? And so they can look at the titles. In our trial, in our study, we didn't have the cost card yet. But the #1 card that patients picked up was the weight change card. To what extent are these medicines causing changes in my weight? And this is very interesting because in the control group, in the usual care arm, the only situation in which patients discussed the changes in their weight was when their doctors were telling them you have to lose weight. And don't mind the medicine that I'm giving to you right now that actually makes it very difficult for you to lose weight. Don't mind that, okay? But in the group that patients were able to participate in decision making, they were able to identify that, for instance, there's a medicine here that can help them lose weight. Well, they may find that very interesting, so then you ask, which aspect of that medicine would you like to learn next? And if, for instance, they find out that daily routine, how to take the medicine, is the next important thing for them, they may find out that it's an injectable medicine, twice a day. Well, some patients will say, to lose weight, I'll inject my eyeballs. No problem, right? And other people say, no, I want to avoid injections. And so it's interesting, at that point, the patient's eyes just move to the first card without any prompting, and they start looking for the second best. And so, for instance, in this case, they may find that this is a compelling medicine for them. Oh, it's a once-a-day tablet. And then they may pick the cost card. And perhaps they were used to taking metformin, which is a 10 cents a day medicine, and they recognize that this one is a $7 a day medicine, 70 times more expensive. Their eyes will go right back to that initial one, and they find that maybe that sulfonylurea with a moderate weight gain and a daily tablet at 10 cents a day is their next one for them. And those patients did not need to become an endocrinologist to figure that out. We've done the same with antidepressants, helping patients with depression decide which antidepressant they would like to take. So that's one approach. That's one aspect of getting people to think about what matters to them and then decide whether the medicines and things we're recommending are for them. But not all forms of non-adherence are due to the patient deciding not to take the medicine. And for that, let me introduce you to John. John is a patient I made up, and just like Frankenstein, the patient showed up in my visit after I made him up. And I suspect that if anyone here has friends, family, or patients, they will recognize someone like John in their lives. So John is a 55-year-old man, and he has diabetes. And he has been on metformin and glipizide, which are 2 diabetes medicines. He also has hypertension. He was on a water pill, but his blood pressure was not getting to goal. And so he was given a second medicine, a beta blocker. And that medicine got him to be a little dizzy all the time, but nobody seemed to care. He has high cholesterol. He has depression. He has a bad back. And he also has pain in his feet, which are due to diabetes. He is obese. Because of all this, his doctor has told me, maybe it's time to go and see an endocrinologist for your diabetes, a podiatrist for your feet, and maybe a dietitian for all these problems that you have with your cholesterol and your diabetes. To do that, he needs to go to the medical center. You know, our colleague from Mayo was pointing out the distances sometimes and the difficulty with some of these patients. So this patient, in fact, has to take time off work and find someone to give him a ride. And then he's going to go there, and what he's going to get is that he's going to get told to avoid the salt, avoid the carbs, avoid the fats. He's going to be told that he needs to exercise, but of course he has a bad back and bad feet, and he has depression. He doesn't know if he can exercise. He's going to be told to check his feet. He has a big belly, cannot look at his feet. So he probably will need someone at home to take a look at his feet, or maybe get a mirror. He's been told to take his pills, but he takes his pills regularly. He's been told to check his sugars. He's been checking his sugars, writing them down, bringing them to the doctor, and the doctor is not looking at those. He's looking at some other measure for his diabetes, and that measure is the hemoglobin A1C, which is higher than what would be desirable. His cholesterol is also higher than it will be desirable, and his weight is parked at 108 kilograms, and that seems to be the only thing the doctors are talking about. He happens to have difficulty with pain and is unable to sleep, but that appears not to be a concern for his physicians. The reason he can't sleep is because he used to work in a company where there were 3 accountants, then 2, and then 1. The work is always now, the deadline is always now. He needs to perform, he needs to bring the work home to complete the work, and he's realizing the numbers are not adding up. And he's worried that this company is going to go under, and he's not going to be able to pay his insurance, he's not going to be able to pay his debt, or he's going to be able to pay his mortgage. Now, the thing that worries him most about his home is not his mortgage, but the fact that his older daughter has come back to live with them, and with her has come 2 grandkids, and these are beautiful girls. And the reason this daughter came to live with them is because her husband has been abusing them, and she's in turn been abusing alcohol, and he's always wasted. And as he is sitting in his lazy boy reviewing, getting the mail, he picks up a letter from his primary care doctor, who is informing him because he's not reaching all these parameters of control of his diabetes and blood pressure and cholesterol, he probably should be looking for another primary care physician. So I would put forward that the problem with John is not that he doesn't understand. It's not that he doesn't have skin in the game. The problem with John is that this healthcare program does not fit his complex life. And what you would think is, as a reasonable clinician, we'll sit down with John and try to co-create a program that John can implement that will help him advance his goals. But instead, in the environment in which we are, of pay for performance and other metrics, what really actually happens is that this clinician is under a lot of pressure, like the clinician that sent that letter to John, in the face of what's happening, to intensify the therapy. And if you intensify the therapy with John, you're going to get only more non-compliance. Is this an isolated situation? No. A national representative survey found that 35% of primary care doctors said they were practicing more aggressive medicine that they would like to practice. Who's in charge? And so why is that? I think that the reason this is happening is because all our guidelines or our policies for care are based on one disease. And the most common chronic condition affecting Americans age 45 and older is multiple chronic conditions. Right now, if you take the average person between 45 and 60, they already have one chronic condition. Over the age of 65, almost everyone has one. About a third to two-thirds, between a third and a half, have two or more chronic conditions. So when the guidelines are based on one disease and they drive treatment around that disease, and you have multiple diseases, you need someone to do a lot of care coordination and prioritization. And we don't have that. We have poor care coordination going on. And so the programs are piling up, and there's increasingly complex regimens. And because people are afraid of the complexity of those regimens, they have to also introduce complex monitoring to keep them safe. That means a lot of visits, a lot of appointments, a lot of blood tests, a lot of tests. And at the same time, we're obviously trying to get these patients who are overwhelmed to do more self-care. And we do that with very minimal support. At the end of the day, this increases the overall treatment burden until eventually the patients can no longer cope, and now we have a problem of treatment fidelity. We're saying you're a non-compliant patient. But in this case, we caused it. Now, at the top, I left some space to point out that there are some macro issues. One, there's an epidemic of risk-defying diseases. It's very difficult to find a healthy person these days. If any of you is healthy, you probably have some problem with access to health care. And the other thing is that if you go to see your doctor and they're saying, well, you have this risk condition, maybe you need to do something about it, like diet, exercise, and eat, this, and you come back 3 months and nothing has happened, you're probably going to be offered a pill. And so there's an enormous promotion of treatments to try to deal with this level of risk. At the end of the day, this is a model that's very helpful. At the end of the day, everyone here has a given capacity to do your thing, to take care of your role in life. And if you are sick, that same capacity has to deal with the work of being a patient. So if you have limited capacity, you can't execute all that work, and as a result, you may not fully access, use care, and enact self-care. If that care that you're not accessing is actually effective, you may have worse outcomes, you have bad outcomes. And if you come to the attention of a physician, the physician may say, well, we need to intensify the treatment, making the balance of workload and capacity worse. If you are sick, the burden of illness goes up, and you can't have the same capacity to do that work. And so again, you have two vicious cycles, one of increasing intensification of treatment at the top, and another one of increasing reduction in capacity. Think of the problem of readmissions to the hospital in this way. The patient gets discharged home in a situation where they have very limited capacity, and the doctors in the hospital may have changed the treatment or intensified the treatment. It's not a surprise that some of those patients, particularly those that don't have capacity to borrow at home, may come back in the form of a readmission. What is the work of being a chronic patient? Well, first is sense making. You need to understand what is going on, what are these treatments, what is my disease, how they relate to one another. Organizing the work and enrolling others. If a person with multiple chronic conditions goes to arrives at a corner of a street, would a Boy Scout help them cross the street? And the answer is no. The patient with chronic condition looks normal. In fact, if you are into the development of apps and this sort of thing, sometimes when you develop information technology applications or tools for patients with chronic conditions, you think they're normal. You think they're just like you. You think they have extra capacity to learn your tool and to put a lot of information in it and follow trends and to print out stuff and put it in the back of their cell phone. They don't. They're barely making. They look normal because of their tremendous effort to look normal. And we just don't see that. It's not obvious to us, and that's the magic of what they can do. So for them to enroll someone to help them out is really tough. It's really tough. So you see that guy, he's filling up his pillbox. That woman next to him is the reason why he's sitting down to fill the pillbox. If she gets sick, he's toast. He has no chance. Then you need to do the work, and then there needs to be reflection and monitoring and appraisal. Is this worth doing? So that when I wake up tomorrow, I will have the energy to do it again. Now, how much time does it take? These are estimates. The amount of research here is extremely limited. On the top, you see here, when you ask people with diabetes, how long do you spend doing your diabetes work? They say about 48 minutes. Why are you not doing everything we asked you to do? And the patient says, because I don't have time. So how much time will it take? Somebody estimated 122 minutes a day. And if you add the administrative task of asking for refills and calling the appointment office and all sorts of things, it's about 143 minutes a day. It is a part-time job. And this is just diabetes. When we looked at our primary care visits at Mayo Clinic, 46 primary care visits, 24-minute duration. These are long visits. There were 83 conversations about the work of being a patient. So this is stuff that's coming up all the time. Unfortunately, 70% of them were left unaddressed. The patient will say, you know, it's really hard for me to remember to take all these pills. And the doctor will say, yeah, it's a lot of pills. Now, who are these patients? Who is at risk of the situation I'm just describing? The easiest way to find them in the practice is to count conditions. So patients with 5 or more conditions are 9 times more likely to be super users. That means to be at the top quartile of visits and labs and tests and imaging and pharmacy visits and number of medications. So these are the people that have to do the most work. These are the people that are exposed to the most of your healthcare. And this is what I was telling you about the proportion of people with one chronic condition. You can see the 50% rule. That's the average person between 40 and 65 has one chronic condition, and a third has 2 or more. You can see after the age of 65, that's much bigger. So what are the sources of capacity that we're talking about? We learned a few minutes ago that illness reduces your capacity. But if we were to think about more holistically about the patient gets their capacity to face chronic disease from their resilience, from their literacy, from their mental health, from their physical health, from their financial health, from their social capital. Are they connected or are they isolated? And from the nature of their environment. So all of a sudden, if you're trying to improve the lot of patients with chronic conditions, here are a number of targets for intervention that could improve healthcare without even touching healthcare. And so one of the things that you have to realize is if you look at socioeconomic status, poor people accumulate comorbidity faster. So the people that have fewer resources need the most help. And what's particularly striking is that the kind of comorbidity, the kind of disease that they accumulate faster tends to be mental comorbidity. And so, again, these are people that are swimming in the deep end of the pool. And there are not very many clinicians, healthcare systems that want to go into the deep end of the pool and help them out. But these are the patients that eventually seek our emergency care, seek our hospital care, because they cannot get the help ambulatorially. So what is the solution to this particular form of poor treatment fidelity? We think it's minimally disruptive medicine. It's the idea of redesigning healthcare to improve the ability of patients to achieve their goals for life and healthcare, while keeping the healthcare footprint on their lives the smallest possible. So how might we do that? First, we need to have a better handle on the burden of treatment. Right now, there is no measure of burden of treatment. Nobody monitors burden of treatment. We don't know how to measure burden of treatment. And there are two teams, one in Paris and the other one in Rochester, Minnesota, that are working on burden of treatment measures. And we have a little competition just to improve my chances. I am a member of both teams. The second thing is the notion of coordination of care. Not in the, I have a care coordinator, I am a patient-centered medical home, and I can check boxes to say we have care coordination. No, really, coordinate care. When there's an appointment in the cardiologist, somebody has to say, you don't need to see the cardiologist. I'll give the cardiologist a call and see what they want, and see what we need to do, and see what they need from you, and I'll try to get that for you, so you don't have to come in extra for that. Or they say you need to come in. We'll synchronize that appointment when you have to come in also for that other appointment and that other x-ray, so that we don't have to bring you every other week. That care coordination. We need to make sure that our policies recognize that the most common condition, most common chronic condition is multiple chronic conditions. And we need to make sure that our guidelines, our pay for performance, all these other things begin to recognize that rather than ignore it. And then we need to learn to prioritize our work from the patient's perspective. And that's actually a little hard. Because when we start measuring the quality of our care, we need to abandon all the generation one measures of quality of care and start to look at the outcomes that patients might report. Want to develop a cool app? Get us a way of knowing how patients are feeling right now. If I'm following my 20 high-risk patients with 9 conditions, I want to know how they're feeling right now, and right now, and right now. And I want to compare how they're feeling now with last week. And I don't want to measure that when they come to see me, because when they come to see me is when they're sick. I want to know how they're doing the other 99.9% of the time, because that's what we're trying to help them with. Help us measure that. And we start to think about other aspects of quality of care that are more about the experience of care. So when we're talking about prioritizing from the patient's perspective, we need to understand what are the patient goals. And the number one goal that patients have is not to improve their diabetes control or blood pressure control or their bone density, is to actually be able to fully play the role they play in their lives. They want to be there for their kids. They want to coach. They want to teach. They want to be a parent. They want to be a spouse. They want to be a good worker. They want to be a good citizen. They want to show up. They want to play the role they need to play. And that is the primary goal of healthcare. And that's what we need to help them achieve, so that healthcare will fit their lives' context. I leave you with one image which I think is very striking. That's a canary, that's a coal miner. And this is a picture taken in 1987. Apparently in England, they were still using this technology to figure out if the air in the coal mine was safe. They'll bring the little canary down. And do you know how they knew that the mine was toxic? The canary died? No. Imagine if a canary died, they had to go and get another canary. No. What happened is, when the canary, first of all, they use a canary because if the air is toxic, there's a little lung, right? Very quickly, the canary will actually get really toxic. So think about the patient with multiple chronic conditions. They touch your healthcare system so many times in so many places that if your system is toxic, the first patients that are going to experience harm will be your patient with multiple chronic conditions, like this canary. But the canary will come down into the coal mine, and the air will be toxic, and the canary will become restless. And then if the canary was not removed, the canary will stop singing. When your patient stops showing up, when your patient stops taking the medicine, it's the canary has stopped singing. The healthcare system has become toxic, and we failed our opportunity to help them achieve a better health. Thank you for your attention.